My name is Jack Davison, and the title of my presentation is Chronic Heart Failure, Diagnostic Methods and Treatment Options. This presentation will outline some of the well-established diagnostic methods of chronic heart failure, as well as the most widely used treatment options. The implications of chronic heart failure for exercise physiologists and the integration of exercise therapy into treating this condition will also be discussed. To begin, it's beneficial to clearly define what chronic heart failure is, which is a syndrome of typical signs and symptoms including breathlessness, ankle swelling, fatigue, elevated jugular venous pressure and displaced apex beat, which result from abnormal cardiac structure or function. Currently, there is no single method that can independently diagnose chronic heart failure. This has largely been due to the fact that heart failure has many causes and varying non-specific symptoms. For example, one of the most common signs seen in heart failure patients is peripheral edema. However, this may potentially stem from other comorbidities. Therefore, diagnosis of this condition relies on multiple testing procedures to discriminate between heart failure and other health issues. This presentation will outline the current most practiced procedures in clinical diagnosis. It will also review some other less specific lab tests that may be of benefit to diagnosing heart failure and correctly identifying its cause. An initial step in the diagnostic process would be to analyse the signs and symptoms and obtain all relevant medical history from the patient. This would include whether there is a previous history of myocardial infarction with the patient or if a family history of cardiac disease exists. Lifestyle behaviours such as smoking, alcohol consumption, diet, physical activity levels and weight should also be reviewed. This history is an important step in early detection of the presence and severity of heart failure. It will also play an important role in informing the rest of the diagnostic procedure. For example, if a patient reports history of previous myocardial infarction, there is a strong likelihood that the patient has heart failure, and as a consequence would be treated with more concern. In contrast, it is unlikely that heart failure is present in a patient who leads a healthy lifestyle, reports no previous cardiopulmonary health issues, and has no family history of cardiac disease. It is plausible that signs and symptoms from this type of patient may be attributable to another health issue. A patient's symptoms would also be clearly considered by a GP or other healthcare professional. As stated earlier, typical symptoms include breathlessness, orthopnea, paroxysmal nocturnal dyspnea, reduced exercise tolerance, fatigue, ankle swelling, and edema. A joint report by the American College of Cardiology and American Heart Association explicitly states in their guidelines to heart failure management that a 12-lead ECG should be undertaken in all patients presenting with symptoms of heart failure. The 12-lead ECG test is the most frequently used, non-invasive diagnostic tool in cardiac investigations and provides important data on electrical activity of the heart, including heart rhythm, electrical conduction, QRS morphology and duration, and other abnormalities. A completely normal ECG will effectively rule out the chance of there being heart failure present in an acute presenting patient. However, it is important to note that a completely normal ECG reading in a non-acute patient may have a slightly less predictive value when investigating potential heart failure. There are a number of different ways in which an ECG can be examined, but as an example, an ECG reading can detect the potential presence of left ventricle hypertrophy, which is commonly seen in heart failure patients. Using the Sokolow-Lyon criteria, this is done by adding the depth of the S wave in lead V1 and the height of the R wave in lead V5 or V6. If this total is greater than 35 millimeters, then the patient has left ventricular hypertrophy, which would give clues to the etiology of heart failure. So the presence of abnormalities in an ECG reading would indicate potential etiology of symptoms. However, despite this, it is widely recognised that an ECG test is not a standalone test for diagnosing heart failure, particularly in patients with chronic symptoms. The work completed by Fonseca and colleagues in 2004 suggested that all patients suspected of heart failure should undergo further diagnostic procedures despite the results of an ECG. This further testing may include echocardiography or blood tests, for natriuretic peptide levels. So another commonly used test in diagnosing heart failure is obtaining natriuretic peptide levels in the blood. Natriuretic peptides are a family of hormones usually released in higher quantities due to heart disease and overload on the heart chambers. The two main types that are usually tested are B-type natriuretic peptide and N-terminal pro-B-type natriuretic peptide. They can also be referred to as brain natriuretic peptides. There is good literature to support BNP levels as a good discriminator of dyspnea, a predictor of left ventricular dysfunction, and its value in prognosis of chronic heart failure. In a 2002 study by Berger and colleagues, they suggest that BNP levels seem to be a good marker of symptomless left ventricular dysfunction. It is important to note that higher levels of these hormones can also be the result of renal failure or increased age. Levels are also slightly higher in females, and therefore these variables would influence a clinician's interpretation of the results. In the guidelines of heart failure management, published by the European Society of Cardiology, the thresholds for natriuretic peptide levels are outlined for patients presenting with acute and non-acute signs and symptoms of heart failure. As we are only really concerned with chronic heart failure, we will focus on the thresholds at the bottom of this slide. For non-acute or chronic patients, the BNP reading would have to be at least 35 picograms per milliliter, or an N-terminal pro-BNP reading of 125 picograms per milliliter of blood. The sensitivity and specificity of using this type of test is lower in chronic patients than in acute patients. Echocardiography. This is the most useful diagnostic tool in assessing patients with suspected heart failure. An echocardiogram will give good data on the structure of the heart. This includes wall thickness, chamber volumes, and valve function. It will also provide information about the diastolic and systolic functions of the heart. This is not only crucial in heart failure diagnosis, but also in defining the etiology of heart failure and subsequent treatment options. The results of an echo will be quantified and interpreted, so if there is an issue with valvular function, treatment options would likely include some form of invasive surgical procedure, whereas other issues may require drug therapy. Just as another example, ejection fraction is an important marker in determining severity of heart failure and its prognosis. The results of an echo will give good data on whether this ejection fraction is normal, which is typically 50% or above, or abnormal, lower than 50%. A value of less than 35% would be considered severe. This value is obtained by dividing the stroke volume by the end diastolic volume, and is easily determined using echocardiography. However, it is important to note that values and ranges of ejection fraction are dependent on various factors, including imaging technique used and the analysis method employed by the operator. Another way in which echocardiography can be used as a diagnostic method includes identifying displaced apex beat. In a study by Davey and colleagues in '97, it was found that, together with past history of myocardial infarction, the displaced apex beat was the single best predictor of left ventricular systolic dysfunction, which is a key marker of chronic heart failure. The benefits of an echo include bedside portability, accuracy, safety, and low cost, with the only disadvantage being that it requires an acoustic window. Despite the recommendation that all patients presenting with signs and symptoms of heart failure should undergo ECG and echocardiography, a recent article published by the American College of Physicians made an important point. This article stated that the use of ECG, stress echo, and myocardial perfusion imaging should be discouraged when assessing low-risk, asymptomatic patients. They contrast the well-known benefits of using these diagnostic methods with the negative aspects in this population. These negative aspects may include the risk associated with stress testing and false positive results that may induce anxiety in the patient. Instead, they encourage focusing on strategies to eliminate modifiable risk factors such as smoking and dietary behaviours. The ACCA AHA guidelines for the management of heart failure report that a two-dimensional echocardiogram coupled with Doppler is highly recommended for use with patients that have or are at risk of heart failure. This recommendation is also reflected in similar guidelines outlined by the European Society of Cardiology. If echocardiography is unavailable, or if results from an echocardiography are insufficient, which may be the case in patients who are obese or have chronic lung disease, cardiac magnetic resonance imaging, or MRI, can be used. There are a number of other imaging methods available, such as transesophageal echocardiography, which may be more suitable in patients with valvular disease. Other cardiac imaging techniques, such as cardiac catheterization and a range of computer tomographies, may be viable options in the absence of echo, but will subject the patient to radiation. To summarize diagnostic methods, the following algorithm demonstrates the suggested course of diagnosis in a clinical setting. An ECG test should be undertaken in patients presenting with chronic symptoms and can be coupled with taking BNP levels. A simple blood test will provide information on BNP levels and will also provide data on other biomarkers of other health issues. For example, a blood test may reveal that a patient is anemic, a condition that can mimic the symptoms of heart failure. Looking at this diagram, and the right-hand side in particular, if ECG results were to return as normal and BNP levels were under the threshold, it is safe to assume that chronic heart failure is unlikely, and other investigations may take place to determine diagnosis. So, for example, a patient may have symptoms of breathlessness on minimal exertion but return normal results in their natriuretic peptide and ECG tests. The patient may have to undergo testing for respiratory diseases instead. Alternatively, if an ECG returns as abnormal or BNP levels are seen to be elevated, then a patient should be referred for echocardiography. The ACCA and AHA's guidelines have clear recommendations as to the treatment options at each stage of heart failure. For the purposes of this presentation, when I refer to the stages of heart failure, it will be primarily based on the American Heart Association's stages of heart failure. This will inform my discussion on the most commonly used types of treatment. These classifications are widely used and take into account a person's exercise capacity and the symptomatic status of the disease. The New York Heart Association has also developed functional classifications for heart failure, which will also be mentioned in the discussion of treatment techniques. In stage A, the patient is considered to only have the risk factors associated with developing heart disease and other cardiovascular health issues. Risk factors include hypertension, blood lipid disorders, obesity, diabetes, smoking, and a sedentary lifestyle. As heart disease is not present at this stage, the patient is encouraged to manage all risk factors. Most of the risk factors outlined here are modifiable and can be reduced with improved lifestyle behaviours. The voice of a clinician and a strong support network can play a vital role in encouraging these behaviours in a patient. However, it is also reasonable for a patient to undergo antihypertensive drug therapy to reduce blood pressure. A patient could be classified in stage B when there are structural changes in the heart, but no symptoms. These patients have typically had a history of myocardial infarction, have a low ejection fraction, or further increased risk factors for developing heart disease. In the ACCA AHA guidelines, they suggest the use of ACE inhibitors and beta blockers. ACE inhibitors, or angiotensin converting enzyme inhibitors, are vasodilators and have been widely acknowledged to be part of routine practice when treating heart failure. ACE inhibitors are normally administered at low doses initially, with the dose being built up over time. Anecdotally, some patients report a metallic taste or loss of taste as a result of using ACE inhibitors, but this is said to improve over time. Use of ACE inhibitors may not be a viable option in all patients. Some patients may develop a strong cough, and it is discouraged for use in patients with kidney failure or really low blood pressure. An alternative to ACE inhibitors is angiotensin receptor blocker, ARB, which essentially performs the same role. Beta blockers have been shown to reduce hospitalizations and are now strongly recommended to be used in conjunction with ACE inhibitors in chronic heart failure therapy. Another option, particularly for those patients who have had myocardial infarction, is an implantable cardioverter defibrillator. This device is small enough to fit in the palm of your hand, typically has 2 leads that connect to the heart, and is surgically implanted into your chest. The device monitors heart rhythm and can send a shock to the heart to treat arrhythmias. This small device has been shown to be effective in patients that have conditions that are not treatable with drug therapy alone. So in stage C, there are structural changes in the heart and symptoms have occurred. Treatment options would largely remain the same in this stage of heart failure, with a strong focus on drug therapy with ACE inhibitors and beta blockers, and further combinations of other drugs such as mineralocorticoid or aldosterone receptor antagonists. Edema is a common symptom experienced by chronic heart failure patients, and diuretics have been shown to be effective in addressing this. As with ACE inhibitors, diuretics may be introduced in low doses at first, but then increased over time. Modest dietary sodium intake is encouraged in patients with heart failure. It may also be beneficial for patients to receive education on heart failure. It has been shown that heart failure education upon discharge can improve self-monitoring, medication adherence, time to hospitalization, and time spent in hospital. There are a number of non-surgical device treatments for heart failure patients. ICD or implantable cardioverter defibrillator, as mentioned earlier, may be an option for the prevention of sudden cardiac death. Cardiac resynchronization therapy may be indicated for patients with New York Heart Association class symptoms 2, 3, and potentially 4 that have a left ventricular ejection fraction of less than 35%, sinus rhythm, left bundle branch block, and an increased QRS morphology. So cardiac resynchronization therapy is achieved with a small device, much like a standard pacemaker or like the ICD I spoke about earlier. This device is used to regulate faulty electrical signals in the heart. Irregular rhythm may stem from bundle branch block, where the electrical signals travel too slowly through the heart, resulting in a weak contraction. Electrical signals from the CRT device will help coordinate electrical activity to improve heart contractions. A CRT-D or cardiac resynchronization therapy defibrillator is more desirable and will perform the function of a CRT and an ICD. Cardiac resynchronization therapy is shown to result in a significant improvement in left ventricle desynchrony and contractile function, according to a 2011 study by Pooler and colleagues. In stage D, the patient has advanced heart failure. Stage D is also being termed end-stage heart failure and refractory heart failure. Symptoms of heart failure are persistently severe and the patient requires aggressive medical therapy. At this stage, patients should be re-evaluated to ensure that correct diagnosis has been made and etiology is precise. This will highlight the potential need for treatment of other comorbidities. If symptoms persist and all pharmacological avenues and non-surgical avenues are exhausted, then invasive surgery may be required. Options such as ventricular reconstruction, ventricular surgery, heart transplant, or mechanical circulatory support may be explored. Exercise as part of cardiac rehabilitation has been shown to be safe and forms part of the AHA guidelines to treat heart failure. Therefore, exercise physiologists can be of assistance to patients who have heart failure. Both the ACCA, AHA and ESC explicitly recommend exercise training as safe and effective for clinically stable patients, particularly those with mild to moderate symptoms. the benefits of which are improved functional capacity, exercise duration, health-related quality of life, and reduced hospitalizations. Another implication for exercise physiologists is that there is currently no universally accepted exercise prescription in chronic heart failure. However, in a position paper by the European Journal of Heart Failure, there are guidelines on implementing exercise training for chronic heart failure patients. The lack of a universal specific exercise program may stem from a lack of consistency in investigations of exercise therapy in chronic heart failure, and the limited amount of large-scale randomized controlled trials in this field. There are, however, a number of studies that investigate specific exercise modalities for heart failure management, such as aerobic training, resistance training, and respiratory training. An interesting study from last year by Adamopoulos and colleagues found that inspiratory muscle training combined with aerobic training provided additional benefits in functional and serum biomarkers in patients with moderate chronic heart failure, a finding that advocates further research into inspiratory muscle training in cardiac rehab. The European Journal of Heart Failure outlines that all exercise types require careful clinical supervision be applied in the initial stages of exercise therapy, which may include the use of ECG for monitoring purposes. After going through the literature, there isn't an abundance of strong research in this area. Further research with large randomized controlled trials are required. More knowledge is needed on how mode, intensity, and duration of exercise affects the severity of chronic heart failure. More insight into this type of therapy would surely enhance and complement the well-established pharmacological approach to treatment. A further implication is that exercise physiologists could play a further role in assisting the profession and patients with prognosis. For example, prognosis is largely determined by functional capacity tests such as the VO2 max test. The result of a VO2 max test would indicate whether the limitation of exercise capacity is limited by cardiac or respiratory issues, and has been found to be a strong indicator of survival amongst chronic heart failure patients, as reported by Broke and colleagues. They also found this measure to be a better predictor of mortality than any resting measurement. There is scope for a patient to be diagnosed initially with this kind of technique, with the potential inclusion of using ECG at the same time, as it would ignore potential renal and hormonal factors that could be affected by other comorbidities. Another useful diagnostic tool is the 6-minute walk test, which is simple, safe, and inexpensive. A study by Rostagno and colleagues found the 6-minute walk test to be an independent predictor of survival in unselected patients with mild to moderate heart failure. As well as being low cost and simple to execute, the 6-minute walk test may be less daunting to patients when compared with VO2 max test. Exercise physiology can be considered a growing profession, and the scope and recognition of the profession could be enhanced through a consistent referral base for patients who have chronic heart failure. Referral for exercise therapy could become an integral part of chronic heart failure management. A strong evidence base would potentially influence established healthcare providers to integrate it into standard heart failure management practice. It could be suggested that in order for this to occur, there also needs to be further education for healthcare providers and patients on the benefits of increased physical activity and exercise. Current research outlines well-established diagnostic and treatment procedures for chronic heart failure at present. However, there is still scope for improvement, as the incidence and prevalence of this condition is still a concern. In the future, further research could lead to exercise physiologists becoming more widely integrated into chronic heart failure management alongside pharmacological interventions. AEPs could play a key role in the management of chronic heart failure in helping patients to improve functional capacity, health-related quality of life, and reduce hospitalizations. This could be achieved with a formal exercise program coupled with education on chronic heart failure management. Exercise physiologists may also have a role to play in emerging and more time and cost-effective diagnostic procedures. However, this all hinges on a growing evidence base for exercise as a therapy in chronic heart failure, and therefore more research needs to be carried out in this area. Thank you for listening to my presentation.